Good afternoon, everyone. Thank you for joining us today for a heart-to-heart talk. And today we are here with two amazing cardiologists, Dr. Rios and Dr. Brian, and they're going to be talking to us about different cardiovascular diseases, what's the effect, how we get sick, how we prevent it, especially because this month, February, is dedicated to heart disease, or I will say heart health month. Rather, I like to talk about health more than disease. So today we're going to be, asking questions, and I'm inviting all of my attendees, as I do every week, to use the Q&A icon at the bottom of your screen or the chat to open those boxes and start asking all the questions that you want. To remember, it's not every day that you can get to talk to cardiologists and ask all your questions, and it's for free and you don't need an insurance card or anything like that. So this is really great to have them here. And as usual, I'm just going to start by asking you to please introduce yourselves. So Dr. Rios, you're new to our community chats. Welcome.
Thank you so much, Sandra. Thank you for the invitation. It's an honor for me to be here and connect with the community in this innovative and new wave. My name is Saul Rios. I was born and raised in Guatemala. That's where I did my medical school. And after finishing medical school, I came to the Bronx. I've worked in Jacobi Medical Center for about 4 years. That's where I did my internal medicine residency. And I worked both at the inpatient and the outpatient level. After a few years there, I decided to specialize further in cardiology. And that's how I ended up here in Montefiore. I've been a fellow here since 2020. And I plan on further specializing in interventional cardiology. So I've been in the Bronx community for a few years now, and I plan on staying in the area for a few more years and providing care to the special community here in New York City, specifically in the Bronx.
Great, thank you so much. Dr. Brian, you're not new to our community chats, and it's a privilege to have you back.
All right, thank you, Sandra, and thank you for the opportunity to be here today. And so I've been in practice for about, it's hard to believe, but I think about 18 years in the Rockland community. I trained at Montefiore Medical Center and actually had done primary care for a couple of years before I went back and did my cardiology fellowship. So I think as a result, cardiology from a prevention standpoint has been, very important to me because it sort of has that primary care almost focus or background as well. But I enjoy doing these talks because, it's the backbone of what I do as a preventive cardiologist is to educate people on heart disease and preventing heart disease. So thank you very much again for the opportunity to participate.
Well, no, thank you for your time. And let's get to business. And I would like to know, we talk about cardiovascular disease and we talk about heart disease. So what's the difference between the two, Dr. Rios?
So when you're talking about cardiovascular disease, you're not only referring to the heart in specific. You have an extensive network of blood vessels that is also part of your cardiovascular system. So when we say cardiovascular disease, we're including all of the diseases that affect your cardiovascular system, and these include your heart and your blood vessels. So blood vessels that supply oxygen and blood to all your body can also have disease. Some patients get disease in the blood vessels that supply oxygen and blood to the legs or to other critical organs, and that can also be considered cardiovascular disease. Whereas heart disease is a little bit more specific, and that involves all of the conditions that affect only the heart specifically and not the peripheral cardiovascular system.
Mm-hmm. Dr. Brian, is there something you'd like to add?
Yeah, sometimes there's I completely agree with everything Dr. Rios said. Sometimes there's a definition or, maybe semantic issue where people use the term heart disease, and when they ask the question or refer to it, they're specifically relating to referring to coronary artery disease, which is probably the most common issue that we deal with, and some of the complications of heart disease that we deal with stem from that. But from a definition standpoint, as Dr. Rios said, heart disease, generally speaking, refers to all these different conditions related to the heart. But a lot of times people say heart disease, but they're specifically referring to coronary artery disease. So just as long as we're clear what we're talking about when we're, referring to one or the other, but just from a definition standpoint.
And Dr. Ryan, are both of them, the cardiovascular disease and the heart disease, treated by a cardiologist, or does it need from different specialists?
I would say from different specialists, because, cardiovascular disease involves even, hypertension within that broad spectrum. And obviously, your primary care physician is quite involved in treating hypertension. It's a multifaceted approach. Cardiovascular disease issues are complex and have a lot to do with your metabolic situation as well too. So endocrinologists and people who treat diabetes and hyperlipidemia, all factors that also contribute to, atherosclerosis and heart disease issues, are all part of the, it's all hands on deck in terms of treating these issues that result in cardiac disease problems.
Mm-hmm. However, I'm under the impression that most of the time when you have either diabetes or hypertension that you just mentioned, you need to seek the help of a cardiologist. Like, you're often referred to a cardiologist. Is that correct?
I'll take this question as a practicing cardiologist. In the community, that is true. It depends on the community you're in. In some environments, a lot of that stuff, obviously in healthcare environments where there isn't easy access to cardiologists, we do rely on primary care providers to fill that role. And a lot of the referrals are for more complicated, people with uncontrolled hypertension or very difficult hyperlipidemia issues to manage. But in general, in practice, it's sort of both things. Primary care physicians, to the degree they're comfortable, will manage those things, but they'll easily refer to cardiologists for more complex management. Or I'll have patients who've had prior cardiac events or issues who need ongoing follow-up for their high blood pressure or diabetes, and we'll manage that. I think what's happening in medicine is, over time, that we realize that so in particular for diabetes, there used to be this distinction between, cardiologists and endocrinologists, and, the endocrinologist would manage the diabetes and the cardiologist would manage other things, when in fact, as a cardiologist, we manage pretty much everything, because diabetes is such an intrinsic part of what contributes to these diseases that you have to be sort of equipped to manage and prescribe medicines for diabetes. And I think that's sort of been changing in cardiology, where our role has sort of become more broad in terms of being able to address those issues as well.
Mm-hmm. That's great. And how do we know if we have heart disease? Are there any warning signs or symptoms? Is it different for men than women, younger people than older people? Dr. Rios, would you like to?
Oh, yes, of course. So, the problem with cardiovascular disease is sometimes that specifically hypertension is known as the silent killer, because we don't get a lot of warning signs before we actually get the disease. So what I would recommend is that everyone gets an annual cardiovascular exam with their primary care physician, and particularly if you have risk factors like a family history of cardiovascular disease, if you have overweight, if you have diabetes or high cholesterol, you are already at risk of cardiovascular disease. So the best way of approaching is a preventative approach, and you will control these risk factors. You will have a close follow-up with your primary care physician or your cardiologist, and this will avoid the disease to actually develop in the first place. Common symptoms, we're all familiar with chest pain. However, this can be very non-specific. Shortness of breath when you exert yourself, a feeling of palpitations. Those are all common symptoms that get referred to us as cardiologists in the clinic. However, none of them are very specific for a particular cardiovascular disease. The approach would be know your risk factors, discuss them with your physician, establish a cardiovascular physician to follow up with, and avoid any of these diseases to progress in the first place.
Dr. Brian?
Yeah, to sort of piggyback on what Dr. Rios just said, a lot of times people sort of have the misconception in terms of symptoms that for it to be a cardiac related symptom or pain, let's say, it has to be on the left side of your chest. And conversely, if it is on the left side of your chest, it's definitely the heart. If it's not on the left side of your chest, then it's not the heart. And what I really try to reiterate to people is that it's not so much the location, but it's sort of the nature of the pain. And as Dr. Rios said, chest pain symptoms in particular with exertion particularly raises an alarm bell, because at rest, there may be enough blood flow if someone has a blockage in an artery that there's no symptom. But when they're active and your heart rate, your blood pressure increases, your heart needs more oxygen, that may be what triggers the symptom of chest pain. So even if it's right-sided neck pain, but it's clearly brought on by exertion or activity, to me that needs further workup to make sure it's not an anginal or angina type symptom, as opposed to someone having sharp left-sided chest pain that lasts 2 seconds and then goes away and only occurs at rest. That by description is less likely to be cardiac related. So just a backup on what Dr. Rios.
So let me see if I understood this correctly. So the pain doesn't necessarily have to be near your left shoulder. It could be anywhere, correct?
Could be anywhere. It could be in your neck. It could be in your jaw. It could be not even pain. It could be shortness of breath. It could be dizziness. It could be, and not to make everyone paranoid that every symptom is related to heart disease. I guess the point being that if it's clearly triggered by exertion or activity, it at least should raise the question or suspicion whether it's heart related. It may prove not to be, but those are the symptoms that sort of get cardiologists' attention, is that description that it's brought on by exertion or activity. Now, again, I'm referring to stable symptoms as opposed to someone who's having, a heart attack that is having, rest symptoms or, wakes up in the middle of the night with crushing chest pain. Different story altogether. That's not exertional, but it's clearly heart related. So I'm talking about someone who's having occasional symptoms, not an acute, cardiac event. The exertional component is the part that raises the concern.
Dr. Rios?
It's also important to keep in mind that women, in particularly people with advanced diabetes or elderly people, present in different ways. You don't always get your classic chest pain in the middle of the chest that's crushing in nature. Particularly females sometimes get non-specific symptoms like fatigue, shortness of breath, sometimes shoulder pain or jaw pain, like Dr. Brian described. So any pain that concerns you and you think it's different, particularly with exertion, or that it doesn't go away after a certain amount of time, I think it's something that should be checked, and particularly keeping in mind that women may present differently than males.
Now, let me ask you something, because this is very interesting to me, and I'm sure to all of our participants as well. If I'm not used to exercise, for example, and then, on a beautiful Sunday afternoon, I decide to go walking, and I start feeling some of this pain, how do I differentiate between, just the fact that I'm mostly sedentary and I'm exercising and I might just be feeling this pain, or that is really an issue out there? How do you know?
You kind of, to what you just described, you may not know. And if it really is a new symptom with exertion that you're noting, and again, while I said exertional symptoms are concerning, by no means does it absolutely mean cardiac. There are other things, based on motion, breathing heavy. It could still be pulmonary, it could be musculoskeletal. It's more concerning for cardiac. But if you're having those new symptoms and you're not sure, honestly, I would probably say you probably should see your doctor and have an evaluation done before you continue doing, regular sustained exercise, just to make sure. And it may be just that you're deconditioned and, you need to exercise, but you want to make sure it's safe to do so before you do that.
Okay. And Dr. Rios, Maria is asking, she has hypertension. Does it mean that she has a higher chance to get any cardiovascular issue? And if so, what kind of cardiovascular issue?
Of course, that's a great question, Maria. Thank you for asking it. So one of the major risk factors for cardiovascular disease is uncontrolled hypertension. So I think the goal for any patient with high blood pressure is keeping a blood pressure that is as close as possible to a normal blood pressure. So as per definition, a normal blood pressure should be a systolic blood pressure less than 120 and a diastolic blood pressure less than 80. So over the years, over time, if you keep the blood pressure under control, very close to a normal number, you will decrease your chance of cardiovascular disease almost to the point that you are at the same level as someone that doesn't have hypertension. So it's not one number, it's not one day, it's a long-term race of controlling your blood pressure and keeping your numbers as close as possible to a normal blood pressure. And at the same time, controlling all of the other risk factors for cardiovascular disease, like your cholesterol, your blood sugar, your activity, and your diet. If you keep all of those in conjunction, then that's how you will decrease your risk for cardiovascular disease.
Mm-hmm. And Dr. Rios, we were talking also about salt, and it looks like there is a relationship also between salt and hypertension, although I know that there is some controversy around, there is some research that link salt intake to hypertension, but then there are some other studies that say it's not true. What do you have to say about that?
Actually, thank you for asking. I prepared a few slides regarding this topic. So I'm just going to share my screen and we're going to briefly dive a little bit deeper into this topic. So, all right. Can you see my screen now?
We do.
Okay, perfect.
I
so
do.
Basically, I wanted to talk about salt because I think it's one of the most common dietary risk factors for cardiovascular disease and one of the ones that we could perhaps control easily because it depends on the food intake that we consume daily. So actually, the human body needs very small amounts of salt to survive. Food that's found naturally is very, very low in salt. It wasn't until about 5,000 years ago that humans discovered the properties of salt to preserve food. So before we had any refrigeration, the way to preserve food was to grab a lot of salt and rub it on fish, for example, and this would preserve the food for weeks or even months at a time. And that's when the value of salt skyrocketed, and some civilizations placed a very high value in salt. And I think that's where the word salary comes from, because in some civilizations, salt was used as a currency, and that's how people would get paid for their wages. So how much salt should I consume per day? People always get confused about this. The current recommendations from the American Heart Association recommend a sodium intake of less than 2.3 grams per day. That's more or less than 1 tablespoon of salt per day. However, several studies have shown that the average American consumes about 3 times the recommended amount. The average sodium intake for an American is about 10 grams of salt per day. So what's the problem with consuming salt? I wanted to make some clarification before we keep talking. So salt has 2 main components. One of them is called sodium, and that's the one that gives us the most trouble, and the other one is chloride. So about 1 gram of sodium equals 2.5 grams of salt. So like you mentioned before, we've seen over many years and over many studies that there's a causal relationship between your salt intake and your blood pressure. What does this mean? That the studies have found that people that consume higher amounts of salt end up having higher numbers of blood pressure. And worldwide, over 3 million deaths in 2017 were attributed to high salt intake. So a lot of people are getting cardiovascular disease. A lot of people are dying because of the dietary patterns that they developed. And it's something that could be changed potentially. And that's why I gather so much interest in this particular topic. So what does salt do to your body? So salt raises your blood pressure by altering the fluid balance inside your body. So your body has fluid inside the blood vessels and outside the blood vessels. And if you consume a higher amount of salt, then the water that's outside of your body will go inside your blood vessels, and that will raise your blood pressure. But that's not the only effect that salt has on your body. Salt has also been shown to be pro-inflammatory. That means that salt can increase inflammation inside your body. It can change your immune response, and it can even change the bacteria that live inside your intestine. That's called your gut microbiome, and it has been shown that salt negatively affects the bacteria that live in your intestine. So all of this can lead to several complications. Higher salt intake has been associated with increased heart dysfunction, increased risk for stroke, increased risk for dementia, increased risk for chronic kidney disease, and even increased risk of stomach cancer and weak bones or osteoporosis. So that's what I wanted to touch upon. One of the best ways of decreasing the amount of salt that you consume in your diet is to increase the amount of raw food that you eat, specifically vegetables and fruits, because all of these natural occurring foods are very low in salt per definition. I always tell my patients to increase the amount of vegetables that they take. When they're looking at their plate, I want them to see at least 2 or 3 portions of different vegetables along with whatever else they are eating too. Avoid any foods that are fried, any foods that are inside cans. They are usually high in sodium because salt is still used as a preservative today. So canned foods are particularly known to have high levels of salt. And I just have this little table here because a lot of people ask me, what is my ideal blood pressure? What's considered a blood pressure that's normal? So the green blood pressure is the numbers that I discussed before. I particularly pay attention to the high number or your systolic blood pressure. And that should always be less than 120 millimeters of mercury. Elevated blood pressure is between 120 and 129. It is still not considered hypertension yet, but it's still highlighted in yellow because when you start to getting into this range, that's when you have to start making some changes, particularly if you're not on medications yet. This is when you should start focusing on your diet and on your exercise to make sure you don't go into the next category, which is considered high blood pressure whenever your systolic is above 130. And finally, I wanted to finish this presentation by telling you how do you measure your blood pressure at home? Because when I see my patients in clinic, I only see one moment of time. I only see one measure. And I'm not interested in only one measure. I'm interested in what your blood pressure is doing at home. How is your blood pressure behaving every single day is more important than the single measurement that we get in clinic. So I tell my patients, you need to sit down and you need to be still for at least 5 minutes. So don't go up the stairs. Try not to take coffee 30 minutes before taking your blood pressure. Try to sit in a quiet room for at least 5 minutes before taking it. The second step, sit correctly. Your feet should be touching the ground. Your feet shouldn't be dangling on the chair. Your arm should be resting on a stable surface. So I tell my patients, sit next to your table, to your dining table, and rest your arm on the table to ensure we get an accurate measurement. Don't measure the blood pressure over your clothes. If you need to remove your shirt, remove it, because measuring over your clothes will add at least 5 to 10 points to your blood pressure, and it will not give us an accurate reading. I tell my patients to try to take your blood pressure at the same time every day. And this is because our blood pressure has variations that naturally occur at different times of the day. So to make it more accurate, I tell them to take their blood pressure more or less at the same time every single day. The next step, take multiple measurements. Again, usually the first measurement is the higher. So I tell them, take at least 2 measurements. And if you have extra time, take at least 3 and keep a blood pressure journal. So you will write down the time, the date, and the numbers that you got for your blood pressure. And that is something that's going to be very helpful for me when you bring your blood pressure journal to clinic. I will have a trend of how your blood pressure is looking at home, and I can give you more precise recommendations regarding your medications or regarding your lifestyle interventions. So that's all I had for you in terms of the slides, and I'm sure I didn't cover everything broadly, but if you have any questions, please feel free to share them over the chat.
Yeah, this is a great review. Thank you so much. You know, like I think it's very clear how salt, high blood pressure can relate to cardiovascular disease. And we are getting questions. So I have high blood pressure and high cholesterol that is controlled by medication and a low salt diet. What are my risks of heart disease if I can keep my numbers controlled? Dr. Brian?
So certainly having those issues controlled will reduce your risk. It doesn't eliminate risk because, I think the important thing as well about cardiovascular disease and atherosclerosis in general, the process of plaque formation in your arteries is that it's caused by multiple things. It's not just high blood pressure. It's not just diabetes. It's partly a inflammatory process. And so there are a lot of things that contribute to it. So, I just tell people that you want to control the things that you can control. You have controllable risk factors that are those things: high blood pressure, diabetes, high cholesterol, whether you smoke or not. So you want to optimize that as best you can. And certainly you are lowering your risk, not only if you're taking the meds, because it's not simply just taking the medication. Plenty of people are on antihypertensive meds but are uncontrolled. You actually want to get your blood pressure down to the recommended targets and have follow-up of your cholesterol numbers as well to make sure that you reach the targets that are specified for your particular risk group. The one thing I want to add regarding the high blood pressure issue as well too is that one common issue I see in the office is this issue of white coat hypertension, where I'll see patients for months and years, and every visit the blood pressure is high. And there's this bargaining back and forth about, I have white coat hypertension. It's only high when I'm in the doctor's office. I think one important point for people to know is that, white coat hypertension in and of itself still has higher consequences when it comes to cardiovascular disease, because there's really nothing specific about the doctor's office. Their blood pressure is probably doing the same thing in other settings as well, too. And there's plenty of data that shows that white coat hypertension may not be as high in terms of consequences or the prevalence of complications of stroke and heart disease as if the blood pressure is high all the time, but it's certainly higher than if the blood pressure is normal when people are seen in the office. So the point is, don't discount your blood pressure being high in the doctor's office and trying to rationalize not being put on medication for that reason.
Mm-hmm. And thank you, Dr. Brian. Now Stephanie's asking, on average, how long does it take to drive down high blood pressure once a person changes their diet and add exercise? Dr. Rios?
Thank you. I think it's difficult to pinpoint an average time, but as you are exercising, your body is already secreting substances that will decrease your blood pressure. In the beginning, your blood pressure is going to go up, your heart rate is going to go up, but just after you exercise, your body is secreting hormones and different chemical reactions that will relax your blood vessels and will decrease your blood pressure. How long will it take to be more sustained? That's a little bit more difficult to answer. You got to keep in mind that exercise is only one part of the big component of mechanisms to control your blood pressure. So your salt intake, your diet, your weight, and your exercise all come together to control your blood pressure. But I would say in a matter of weeks, you will see an improvement in your blood pressure. However, there's only a limit to how much you can lower your blood pressure with diet and exercise. It's always recommended regardless, but some people that already have high blood pressure may only be able to decrease their blood pressure numbers by 5, by 10, and even by 15, I would say is a long stretch. So at some point, even if you keep exercising, you will still require medications to give you that extra push and keep a perfect blood pressure and decrease your cardiovascular risk.
Mm-hmm. Dr. Brian?
No, I agree. I think, a lot of times too with follow-up, things are done in a staged approach. So, including when you get put on medications as well, we see people in follow-up, and it may take, as Dr. Rios said, several, weeks before you achieve the sort of target blood pressure. And a lot of it has to do with where you're starting from before, you enact these interventions. So someone who is, much higher to begin with, it may take longer to achieve the recommended goals, even with medication. So as long as people have follow-up and are compliant with, the dietary recommendations and getting it reevaluated, as long as it happens over time, it's not as critical how quickly, except for people with markedly elevated blood pressure where you're worried about more immediate, consequences.
Now, is it possible, we're talking about diet, exercise, is it truly possible to get off medications once you've been prescribed?
It is possible to get off medications. When I counsel people who are often reluctant to go on medicines in the first place, if they need to get started on medicines right away based on my concern, I always leave it out there that if the person makes the recommended lifestyle and dietary changes and we see improvement in the numbers over time, I'll occasionally, do a trial of trying to wean or take people off medication. Now, if they follow up and nothing's changed, their diet's the same, their weight's the same, and you really wouldn't expect a different result. So there'd be no reason to take someone off medication. But certainly, I sometimes put that carrot out there that, yes, if you do this, this, and that, we could always reassess and decide whether, you're able to come off medications or not.
Now, Stephanie's asking, what are your thoughts on the medication nifedipine?
I think it's a great medication. I've used it in patients both in the hospital and outside in the hospital and clinic. Of course, everyone reacts in different ways, so I try to look for the medication that's right for my patient. If they have other comorbidities, if they have diabetes, or if they have heart failure, then I try to cater to a medication that's appropriate for them in the right setting. But for someone that has just high blood pressure and is starting, it's a great medication to start treatment for high blood pressure.
Now, nifedipine is a medication for high blood pressure. Are there medications also for the heart, for heart disease, Dr. Brian?
Certainly people that have, and when you refer to heart disease, if we're talking about, atherosclerosis or coronary artery disease, certainly there are medicines that we use quite commonly. Probably the most common medication would be cholesterol-lowering drugs or statins. And yes, they lower cholesterol, but we also use statins because they have anti-plaque benefits as it comes to the arteries in the heart. So as I mentioned before, that plaque process, formation process in your arteries is affected by many different things, including inflammation. And statins have anti-inflammatory benefits that can improve that. And also the effect that it has on lowering systemic cholesterol levels also, affects the incorporation of cholesterol into the arterial wall and can lower the risk of complications related to atherosclerosis. So statins are definitely part of the regimen of drugs that we use. People that have established heart disease are often on beta blocker medicines like metoprolol. And that's more on the principle that those medicines reduce your heart rate and blood pressure and how hard your heart has to work. And the heart operates on the principle of supply and demand. So if you sort of limit how hard the heart has to work, then you may not need or get away with less blood flow if someone had an arterial issue. And then aspirin is also another common medicine that people with coronary heart disease take. There's been a lot of stuff in the media recently about aspirin use and the aspirin not necessarily being indicated for patients, which has somewhat been misinterpreted because I've had a lot of patients who stopped taking aspirin who still needed it. I think the point being that people who are taking aspirin just for preventive measures, kind of just because don't need it anymore, but people with known, heart disease, coronary artery disease should be on aspirin. And then just, there are a whole host of other medicines that are used as well for just cardiovascular disease in general. But as it relates to coronary artery disease, I would say aspirin, statins, beta blockers, and there are also newer medicines. I mentioned about the interplay between, diabetes and coronary artery disease. Cardiologists, as I said, are also becoming more involved in prescribing those medicines that have glucose lowering effects, but also have beneficial effects as it relates to preventing cardiac events. So those are things that people will hear more about as time goes on, is other medicines that have that glucose lowering effect that also help heart disease issues as well.
And since we are talking about medications, are there any supplements that can also help with heart health?
There are a lot of studies going on. Unfortunately, the ones that we can get over the counter sometimes don't give us the most benefit, but definitely medical grade fish oil supplements have been studied very closely, but not the ones that you get at the pharmacy. Unfortunately, those don't have enough of the right fish oil to prevent cardiovascular disease. But if you qualify for it, if your triglycerides are high, for example, your physician could prescribe medical grade fish oil that can actually lower your triglycerides and your risk for cardiovascular disease. Other than that, some patients that want to try a natural approach to decrease the blood pressure, garlic supplement has sometimes been shown to decrease your blood pressure. It's not a substitute for medications or for a healthy lifestyle, but it's something that could help the drip off some points of your blood pressure numbers. But that's the experience I've had myself.
Yeah, I think there's a role for supplements. The only caution I have is, we'll have patients who take, 8 different supplements. They're averse to taking prescription medicines, but they'll take 8 different supplements with no proven benefit. And it's not to say that there may not be some effectiveness. There might be a physiologic reason why those things may be helpful, but without, randomized controlled trials showing clear benefit, I kind of caution people not to take things like that. There have been examples over the years of things that we used to prescribe that ultimately were proven not only to not have benefit, but potentially harm. I remember years ago, we used to prescribe, high dose folic acid for presumed, cardiovascular benefit. And it, didn't bear out to be effective. And same with people taking niacin over the counter. That ultimately we really don't recommend anymore. Even prescription niacin or niaspan, that was what people were taking, didn't bear out. So the point being that things that aren't regulated or studied, I'd be very cautious about just presumptively taking them.
Yeah, important to note that dietary supplements are not required by the FDA to go the same stringent regulations and testing that actual medications have to go through. So dietary supplements are not tested the same way as your medications are. So sometimes effectiveness and safety is a little bit more difficult to pinpoint, given that they did not undergo these strenuous investigation phases or clinical trials like medications usually do.
Yeah. And to back up what Dr. Rios said earlier about fish oil, that certainly was a common supplement that a lot of people took based on data that suggested, benefit, but it's become increasingly clear that the common fish oil supplements are not really beneficial, and it's really the high grade purified fish oil that has benefit. And so my patients who've been taking just over the counter fish oil, I've largely, taken them all off of it and look for a reason, if one exists to justify them being on a prescription fish oil that has proven cardiovascular benefit.
Can you use prescription fish oil as a preventive measure for hypertension, cardiovascular disease, and heart disease eventually?
Using it and it being approved are two different things. So I wouldn't necessarily recommend people take it just as a preventive. I mean, it's really indicated for people with established atherosclerotic heart disease, and certainly if their triglycerides are suboptimal. But people taking it just sort of presumptively. People do it. I wouldn't necessarily recommend it. And again, it's prescription anyway, so you're going to have to get it prescribed by a physician. But one, your physician has to think it's appropriate, and two, it has to, pass the powers that be, the insurance companies, in terms of whether or not they're going to cover it being prescribed. But it at least is exciting that there is data that shows, clinical benefit to where in the appropriate patients, there are things that should be prescribed and taken.
Mm-hmm. And Mary's asking, please talk about pulmonary hypertension. How does it differ from the measured blood pressure you're speaking about?
Of course. So the measured blood pressure that we're referring to is also known as the systemic blood pressure. It's the blood pressure that is at the same level of all of your organs and is not the same as pulmonary hypertension. The pulmonary hypertension that she's referring to is the pressure that it's inside of your lungs. And that one we cannot typically measure. That one we measured in a specialized procedure that's called a right heart catheterization, or sometimes we can measure it with an echocardiogram. So patients that have pulmonary hypertension take different medications and they have different risk factors for this particular disease. It's not really related to your peripheral blood pressure or your hypertension as we're discussing here. It's a complex disease and something that would warrant for sure another hour of commentary and investigation.
That's another topic for another chat. There you
yes,
go. Write it
definitely
down.
an interesting one, by the way.
Okay, and Dr. Brian, Maria is asking, can stress and emotional issues interfere with your blood pressure and cardiovascular health?
Yes, certainly. I mean, there's a lot of data that shows that, chronic stress, has a lot of negative effects. Certainly can increase your blood pressure, can increase, cortisol levels and other hormonal levels that can have a negative impact. And of course, also acute emotional stress can have immediate effects on the heart as well too. It's sort of become popularized, this issue of stress-induced cardiomyopathy, or the broken heart syndrome terminology, where people, again, but severe emotional stress causing acute effects on the heart that can cause vasoconstriction of blood vessels and cause acute damage to the heart. But just on a generic level, just general chronic stress, which, let's face it, I think the lifestyle that we generally lead in the country and in the world, the way things are right now, I think does have negative impact on people long term from a cardiovascular standpoint, not only in blood pressure, but in terms of risk of stroke, in terms of cardiovascular disease issues in general. So if it's another prong of the risk factor issues that I think should also not be ignored in terms of addressing chronic stress.
Mm-hmm. And, we're running out of time, but I think that it's important that we talk about what to do if we suspect that we're having a heart attack.
Definitely. I think you should, and more importantly, whenever you develop symptoms that are new, that are persistent, and that are consistent with something that looks like a heart attack, you shouldn't doubt and call an ambulance, call your physician, and get additional help. Because some people would try to defer going to the hospital because they are not sure if it is or it isn't, but the only way of determining it is actually getting to a medical facility, getting additional testing and an evaluation by a physician. So I would say if you are suspecting based on the symptoms and based on something that's new, you're not feeling comfortable, don't think about it twice, get to your closest physician and have yourself evaluated and do the proper testing. It's better to be safe than be sorry, because delaying the treatment for a heart attack, unfortunately, can have severe consequences.
Mm-hmm.
Yeah, agreed. It's a double-edged sword where you don't want people to have, paranoia. But as Dr. Rios said, it's better safe than sorry. There are plenty of people who had, what they thought were days of acid reflux that turned out was, a heart attack that, could have been addressed earlier. So I think the bottom line is you either, if they're acute symptoms, you go to the emergency room. If they're not so acute, seek the advice of your physician as to what to do. But what you don't do is ignore it.
And what are the tests that can be done to know for sure if you have heart issues? Dr. Brian?
So if you're having symptoms, I think, they're the basic things your physician will do in the office, like an EKG, which has limited, benefit. Not limited, but it can show obvious things or active things, but a normal EKG does not rule out having a heart issue. Same with an echocardiogram, which is a sonogram of the heart that could be done. If the specific symptom is chest pain, the test your doctor would likely do or begin with is something like a stress test of some sort, either on a treadmill or a chemically induced stress test. And those are the tests, sort of the gatekeeper tests to decide whether you really think the person has a coronary artery disease issue or not. And then, for the sake of time, without going into too much detail, if that's abnormal, or if we were suspicious enough, then there's certainly more advanced testing people might have done, either a non-invasive CAT scan, angiogram to look at the arteries in the heart, or an invasive angiogram, that's done in a cath lab to see if they indeed have, a blockage issue. And then, in relation to chest pain symptoms and evaluating coronary disease, so the kind of typical test, usually in a stage fashion, but as I mentioned, if we're suspicious enough, sometimes we'll cut to the chase and recommend even an angiogram in the right patient.
Mm-hmm. And is there a specific age where we should start visiting a cardiologist and getting some, checkups for our heart in terms of prevention?
I don't think we have a specific cutoff. If you have cardiovascular risk factor in your family, a first-degree relative that had a cardiovascular condition, and particularly if they developed that cardiovascular condition at an early age, then you have an increased risk. So if my sibling or if my father had a heart attack at age 36, I would like to be screened for cardiovascular disease at an earlier age than the average person. But in general, I think anyone above age 35 should get a general checkup by a physician. And if something is abnormal, then they should be referred to a cardiovascular specialist for further testing. And anyone that already has a diagnosed condition or family history or additional risk factors, they should be screened at an earlier age.
Yeah, I agree. It's never too early. And if nothing else, that initial visit might at least, initiate the conversation about, risk factors and addressing, even if there's no need for any particular testing or real concern, it's never too early to start, addressing and educating people about, lifestyle issues and prevention. So agree with Dr. Rios' sentiments.
And Dr. Brian, what's the, I will say, survival rate of a heart attack after you have a heart attack?
It's a hard question to answer because there's such a wide spectrum of types of heart attacks. What I will say is that based on, modern technology, it's certainly much better than it was, 30, 40 years ago, where people basically just sat in a hospital and waited for recovery after they had heart muscle damage. With the advent of cath labs and primary angioplasty for people with heart attacks, the survival rate is significantly better than when it was. And not only that, people that survive heart attacks, with modern therapies, also, things like cardiac rehab, which help to rehabilitate people after heart attacks, has had a significant impact on survival after heart attack. So that's the one sort of amazing aspect of cardiology. Even though the prevalence of heart disease based on risk factors and obesity and diabetes seems to be going up, the survival rate from acute events have certainly gotten better based on modern technology. So that's one thing we can prevention is still where the key should be, but we should celebrate the fact that, we have that.
Mm-hmm. And you just mentioned cardiac rehab. So what does cardiac rehab do?
Mm-hmm. So, most of the patients that are candidates for cardiac rehab are people post either cardiac events or coronary intervention. They had bypass surgery or coronary stent placement. It's not isolated to those circumstances, but what we find, and there's tons of data that show that people that go through a cardiac rehab program after those events do better. Their mortality is better. They have better performance status afterwards. There's less recurrent cardiac events as well. So any patient that fits that scenario, I highly encourage to go through a cardiac rehab program. And we've had many people who not only went through the requisite, whether it's 12 weeks or 16 weeks of rehab, some who even continued afterwards because they do exercise training, supervised exercise training, which is important in someone after an event to make sure they can safely get back into exercise. But it reinforces just a lot of the heart healthy lifestyle and long-term exercise benefits where people can graduate and continue those, efforts on their own when they complete the program. So cardiac rehab's also been a life-saving, literally, strategy that we employ after people have heart attacks.
And how soon should you start cardiac rehab after a heart intervention?
Yeah. Usually I'll wait a month or so after someone has an event before I refer them, but it depends because it also depends what their event was and how sick they are. But usually it's around that time point that I would, I'll refer people during the hospital just to kind of get them hooked in. But in terms of them actually starting, it's usually around that time frame that they sort of, begin that process.
Yeah, okay. It's a great resource that unfortunately is underutilized, but the standard of care here at Montefiore, anyone that had a cardiac event, a heart attack, they get referred during the same hospitalization, and then they establish care and usually start their cardiac rehabilitation about 2 weeks after their initial event.
Can people who haven't had heart surgery still do cardiac rehab, like in a way of preventing surgery?
I don't think I've seen that done before. I guess that would just qualify as regular rehabilitation if they actually need it, or just supervised exercise. But cardiac rehab was mostly designed for people that had a heart attack as a way of encouraging exercise in a supervised environment and making sure that the patient had a good progression of their exercise capacity under strict supervision, and they would continue to doing so once they go back home.
Mm-hmm. Okay, well, we have 3 minutes left and I could talk to you for like 1 more hour because I still have so many questions and I'm sure that other people will too. But what will be your last thoughts? Like, what will be your recommendation for the people that are listening us today and also that will be watching the recording?
Well, I would like to finish by saying that for cardiovascular disease, you have things that you can control and things that you cannot control in terms of your risk. So I think you should be proactive in terms of your health and take control of the things that you can actually change, particularly your diet, your lifestyle, your weight. If you smoke or you don't smoke, all of those things, you should be proactive and make sure that you are controlling them, making sure that you are aware of what a healthy lifestyle looks like in order to prevent cardiovascular disease. And you can start by doing simple things. You don't have to change your life and do a complete change of your usual habits, but something as simple as reducing the amount of salt that you're taking, like we discussed earlier, will have a huge impact in the long term of your cardiovascular health.
Yeah, agreed. I mean, I think it's about people being proactive. I think people need to be educated. People need to ask questions of their physicians. Everyone should know what their LDL cholesterol is. They should know what their hemoglobin A1C or fasting glucose is. They should know what their resting blood pressure is. Just as a starting point, just numbers that, will give them a sense of what their risk is. There are even actual, calculators you can, web-based or app-based calculators you can have on your phone that can help people to estimate what their cardiovascular risk is. And if it does nothing more than maybe, bring them to their physician to say, should I be evaluated more for heart disease, then it's worthwhile. I think it's just a matter of being attentive and being proactive, as Dr. Rios said.
Mm-hmm. Well, thank you so much, Dr. Brian, Dr. Rios, for joining us today. Please expect another email from me soon because this conversation has to continue and I'm sure that a lot of people like this information and like to ask more questions. And next week, we're going to be talking about something that you might think is completely unrelated to the heart, as is eating disorders, but you probably don't know that a lot of eating disorders can actually end in a heart attack. So we keep the conversation going about the heart and how to keep our heart healthy, celebrating February as Heart Health Month. And I will see you next week, Thursday at 12 again. Thank you all.
Thank you so
Have a
much,
good day.
Sandra. Have a good day too.
All right, take care.